Good afternoon, everyone. Unless you're on the West Coast, then it's good morning. And happy to be here. And thank you for having me back to talk more about the issues that are close to my heart and hopefully your own. And that is our cardiovascular mortality. But I think even at the end of a pandemic, if we are indeed at the end of this hybrid issue of Omicron splitting into two different mutations and combining together. Well, we may see some more of it, but I think the principles that I'm going to talk about today are going to be sort of lasting throughout the pandemic. And so I have entitled this. I think it's not really fair to talk about something like nutrition and cardiovascular mortality, which I've done at Real Truth for so many years, without addressing the pandemic. And that is because you'll see why when I get into the data. But we are really in the middle of, or hopefully towards the end of a dual pandemic, and nutrition is key to actually helping. And so, if I can just to set this up, Dr. Mossafarian, who's at Tufts and is dean there in nutrition, we had a wonderful symposium last week at the American College of Cardiology, and I actually borrowed some of his slides, and hopefully he'll borrow some of mine. Just to talk about, because until I saw this, I kind of thought that because I was a cardiologist, actually, I didn't update my CV. I'm actually taking over as chairman of medicine at University of Louisville. But I've always thought for 40 years, I thought as a cardiologist. And so, of course, even though tobacco use is big and dietary risk is big, high blood pressure, which of course is diet, high blood pressure was always the number one cause of cardiovascular mortality around the world, including at-risk populations, United States, disproportionately in the African Americans, who therefore have a higher cardiovascular mortality than other races in the U.S. But now that I'm an internal medicine chair, I have to kind of like back off and start thinking more globally. And dietary risk goes far beyond cardiovascular disease. And it is the number one cause of poor health if we look at the United States burden of disease. What are the results? We have 1 out of 2 Americans having diabetes or pre-diabetes. 3 out of 4 are overweight or obese. So we've kind of combined those two in modern lingo, calling it diabesity. And we have diabesity coming in very large numbers. Only 1 in 10 are metabolically healthy. And when we look at what's about to happen, that is what's going to happen with our next generation, when 1 in 4 are actually overweight or obese, 1 in 5 have prediabetes. Fatty liver disease is happening because when you're making yourself fat, it does involve your organs. What we haven't focused on, and I'll just throw it out there, is that the visceral fat, as it's called, that is the fat that's on the inside of the belly. Everybody can see the fat that's on the belly, but that so-called inside or internal fat actually starts to happen around the heart as well. And so the epicardial fat, as it's called, the visceral fat, actually does result in worsening of coronary heart disease. And so everyone who's getting a CT scan these days of their chest, hopefully in the next few years, everyone will have that little parameter measured because it's such a reflection of future risk. Okay, so we could talk about the weight of the problem, but we can also talk about the cost of the problem. And we have one of the worst healthcare systems in terms of how much we spend and how much we get out of it. And so we have, if the United States is a wonderful place if you get sick, because our healthcare system is actually really good, but it's not a great place to be well. That is the way I will talk about marketing food. We'll talk about food consumption. We'll talk about congressional subsidies for unhealthy foods that affect our population. And so our costs are astronomical compared to the outcome that we have, even though we have an amazing ability to take care of patients. We have pharmaceutical industry that is absolutely unparalleled around the world, but they also charge us more than they do other places. And they don't get mad at me for saying it out loud because they admit it. They say that all the research and development comes from the United States, and for the entire population of the world, it seems. And so this is what we're up against. Instead of roads, bridges, and education for poor people, we're spending it on healthcare because of the choices that we all make. And so setting it up in the pandemic, I'm going to talk over and over again about inflammation and the fact that there are factors inside our bodies that are controlled by nutrition that result in the major risk factors that make people have a bad outcome from COVID: diabetes, hypertension, diet-related diseases. And this is something that we could, if we had jumped on this, and everyone talked about it just a little bit, but they didn't prioritize it as far as I could see. We were all talking about it in our academic circles, and we were talking about it in nutrition circles. And you had PCRM Neil Barnard's group, within 1 month of the beginning of the pandemic, coming out and saying, hey, fruits and vegetables, everybody. And so we'll talk about it. But the fact of the matter is, we did not jump on this fast enough. And many, many people died because they were continued to do the kinds of things that make us, in terms of nutrition, obese, diabetic, hypertensive, and high cholesterol. Now, I do need to back off. We had problems before the pandemic. We had this issue of 195 countries published years ago that the biggest risk factor for dying and disability-adjusted life years in the hundreds of millions was actually due to dietary factors, including sodium, low intake of whole grains, low intake of fruits and vegetables. And so these are things that could have been, that we could fix around the world. But I have to focus on the United States, because look at this graph. This is life expectancy versus the dollars we just talked about. And the United States is such an outlier compared to everyone else. That is, we spend more money and get the worst outcomes of any of the developed world. And this is something that we can't be proud of, and it's something we have to make interventions of. And I'm saying spend less. I'm saying be healthier, live longer, and that way we will spend less. So we have to start with prevention. Back to COVID for a moment. This is a nice, complicated slide. You might want to, snap a screenshot if the Real Truth people allowed that, and just take a look at all the things that led to susceptibility of COVID-19, because it's going to happen again. Maybe it'll be 100 years like the Spanish flu, but maybe it'll be something else. And all of the pandemic issues are related to so many things that we could have fixed. Having poor people who have food insecurity, eating unhealthy food, sedentary behavior, but having the obesity and overweight, and people being undernourished as well. And that is, people talk about food deserts, but there's also food apartheid, where you have good neighborhoods and bad neighborhoods. And you also have, food that essentially that really should be not consumed because it's not nutritious. And we will go through all of this and what the biological effects of these foods are. But ultimately, we have to recognize that this complex issue that we've had with COVID-19 and mortality really revolves around nutrition and our lifestyle. And so one of the things that we always point out is how everyone jumped on the people of color dying more of COVID-19. And it took some very insightful people to say, wait a minute, is it race? Is there something genetic? Well, first of all, we know that the genetics between Blacks and whites and Hispanics are pretty much all identical anyway, with very few genetic differences. And so you wouldn't expect that there's going to be some increased susceptibility to a virus. And sure enough, when you look at things like low income and obesity and kidney disease, when you look at things like that, then you find out that actually being Black in a couple of their models, for those of you who are not used to hazard ratios, if it's less than 1, that means protection. If it's more than 1, it means increase. Well, the biggest model that included all the risk factors that they could put their hands on showed that being Black actually had about 11% less chance of dying if you can correct for all these things. The problem is that the Black people had poorer kidneys and higher C-reactive protein, and they were actually more obese. And that really is the issue. It isn't race, it's risk. And so that was published in New England Journal of Medicine. Hopefully everyone heard that. And we stopped talking about it as if it's a racial issue. It's social and demographics, as well as the issues of health and obesity. So let's talk about obesity for a minute and nutrition. Because we've had this data, and those of you who have been watching, and I know this is a 17-day course, and you may be coming in and out, but you should be familiar with the idea that there are some pretty broad swaths at research and nutrition, and it's hard to get two people, even in the same camp or similar camps, to agree completely on everything. But the fact is that if you compare a plant-based diet to one of those diets that kills you basically by eating a lot of animals, which we'll go through later, you can lose weight on any of them. Why? Because people are lowering their calories. But the question is, how do you sustain it? And it turns out that the data very clearly from Mike Danziger, published years ago, says that plant-based nutrition gives you a better shot at maintaining that weight off. Now, how about diabetes? So I'm not going to spend overwhelming amount talking about any of them, but I want to talk about diabetes because the data is very clear that if you were to do an intervention, just like the obesity data, you do an intervention with plants, what you end up with is lower hemoglobin A1C. That's a measure of how high your sugar's been for the past couple of months. And the only one that didn't seem to work very well, this one study, was not completely plant-based. Instead of low-fat vegan, it was lacto-ovo vegetarian. And so there is some data saying that compared to other omnivorous diets, if you switch from red meat to dairy, that your diabetes risk goes down. I'm sure that's true just because of the effects of red meat. But when you're comparing dairy versus plants, it's going to lose every time. How about blood pressure? Really important to take this data to the bank because it's a massive amount of data. It's been infused into our guidelines, our 2017 hypertensive guidelines. I was happy to be in the room and be part of the authorship of that and to ensure that we had all of the data that says that when you do a plant-based intervention, you're going to see a dramatic drop in blood pressure. Now, the good news is the blood pressure is going to get better. The bad news is the rest of those guidelines have been largely ignored. Not just changing the definition of hypertension to 130/80. That got ignored by a lot of people. But the request that we stop doing blood pressures in offices and taking them seriously. Sometimes people are so much better off in my office than they are at home because of the bad environment that they live in, that their blood pressure could be 30 millimeters lower in the office. But the usual thing that most people have heard of is the office hypertension. And so you really don't know what you have. Now, office hypertension, turns out it does predict future hypertension, but you don't treat that with medications now. You need to have the blood pressures at home. So please, if you're a physician, nurse, make sure that everybody is giving you the blood pressures at home. And if you are the person with hypertension, measuring them at home, even every day if you're taking blood pressure pills. And the reason I went off on this tangent is that I've had some patients, based on the data that you're seeing here, I've had some patients get themselves into trouble taking medication for blood pressure that had dropped a lot when they changed their diet, and they weren't doing what I asked, which is home blood pressures. So home blood pressures for everyone who's at risk, has high blood pressure, or is taking medicine, or is changing their diet, doing an exercise program. Your blood pressure is going to fall. When you cut back on alcohol, your blood pressure is going to fall. When you lose weight, blood pressure is going to fall, and you may not need the same amount of medications. Okay. This is some of the evidence that is very graphic. And I pulled it out because everyone talks about the DASH trial, cutting your sodium, cutting back on saturated fat. Well, their DASH actually fell into 3 different groups. It had some dairy products, but it was not, low in fruits and vegetables, just lowering the sodium, but otherwise it wasn't that good. And then one that was enriched in fruits and vegetables and fiber, and then one enriched in fruits and vegetables and low in fat and cholesterol, meaning more vegetarian or vegan. And you can see the difference in blood pressure is tremendous. The more fruits and vegetables that you have, the better your arteries are going to respond. The nitric oxide that everyone's heard about will actually increase the ability of the blood vessels to open up and relax, which means more blood flow with less blood pressure.